we are in the mid talk, when we are told about the proctoscopy, this is something what is very common in our clinics.
1 minute.
Sir.
I request Dr. Ramani, I request Dr. Gangadhar and Rahate sir, please come to the chairperson for this session.
It's better seen from here. No, we can manage it.
Hey, madam. And Narasimhara garu, randi. Session for this.
Yes, sir. Yes, sir. Whatever you say. So I'm honored to have so many senior surgeons as my chairperson for the session. So as you all might recall that this was the picture that we would see in our proctology clinics. And I don't know, I could not see personally what grade 1, grade 2, grade 3 piles are. The professor or the SR would say that, okay, this is the pathology. And then we would all agree, okay, that is the pathology over there. But then we all must understand कि जंगल में मोर नाचा किसने देखा, right? So what is happening inside the anal canal, what is the pathology over there? If you have not seen it, it is not there. So ladies and gentlemen, I am Dr. Priyank Chelawat and I will today be redefining proctoscopy for you. Now imagine having a disease process that distresses you every day, which cannot be seen, cannot be articulated. Sometimes the patient himself cannot articulate what he is having. He will just come to you and say that I am having piles, I am not feeling well, I am having constipation or something like that. And even talking about perianal diseases is considered to be a taboo among males and females alike. So as you see, it's become something like Lord Voldemort from Harry Potter movies, that he who must not be named. This is where the importance of proctoscopy comes in. So proctoscopy is the art of first communion. It is the marriage between the patient's complaints, surgical assessment, diagnosis and further treatment, So this is what is proctoscopy for us. Now, once the proctoscopy is done, it offers a solution and understanding of the disease better. So it aids in diagnosis, it aids in offering correct treatment, surgical education, patient education and follow-ups. Well, an added advantage is, when you do a traditional proctoscopy, once it is done, it is done. There is no going back, right? You cannot go back again and take the patient again and again for the proctoscopy. Whereas in video proctoscopy, which is my topic for today, you can save the videos, interesting findings can be reviewed, revised and presented. So as rightly said in Bollywood, कि कौन है जिसने मुड़ के दोबारा मुझे नहीं देखा? So video proctoscopy is something which is going to turn back and look back at the pathology. Let me give you an example of video proctoscopy. So you can see this is the proper image that is being shown. And you all can appreciate that these are grade 2 piles based on the anatomical variations. And this is something that is obtained by doing a video proctoscopy. There are a lot of video proctoscopy platforms that are available today, which is the Smart Scope Procto, right? This one. Endostation mobile, action camera adapter, mobile phones, hospital endoscopy stacks. They all range from 30,000-40,000 to 2 to 4 lakhs. Okay, and these are the other instrumentations that are available today in the market. This is all I could find on the net. And this is something that is there. You have all sorts of video platforms. You can attach a mobile phone, you can show the patient and all that. But they all have a limitation. None of them is self-cleaning. None of them is rigid. So this was the moment of truth for me. Once I went to an ISCP conference, I saw such a platform. Okay, this is very good and it should be done for all the patients. But then I thought, why not? I already have this. So I'll just continue the prologue. So I just thought that, why not, I already am doing upper GI endoscopies, colonoscopies. So I already had a video proctoscope in the form of a colonoscope or a laparoscope with me. So I was already armored to do video proctoscopy. So thus came our personal experience. Since we were already doing upper GI endoscopy and colonoscopy on Olympus 170 narrow band imaging enabled system with the best available software, we had flexible scope with inbuilt irrigation and biopsy systems. So all we needed were prerequisites like the patient, scope and screen, team, transparent proctoscope, jelly, and a reporting software. This is the position, which is, all this is very routine that you all are doing. So this is the position of the patient, and what I like to keep is a monitor in front of the patient. Can I have a lighter marker? So you can see that in the second image, the patient is lying on his back, and there is a monitor in front of him. So whatever I say to the patient can actually visually see in front of the screen, you know. So you cannot look back and see the pathology. That becomes very distressing. But in video proctoscopy, the patient is seeing it real time and he is participating in the investigation. This is my setup that I use for video proctoscopy. I use 2 monitors, I use an endoscopy stack, and I use at least 2 assistants. One to hold the video endoscope for me, because one hand is busy holding the proctoscope, one hand is busy doing the proctoscopy. These are all the instruments that you are going to require, nothing apart from this: artery, gauge piece, pad, and a transparent proctoscope. Problem mitigation, shape the patient for best results. It is true for the traditional proctoscopy as well. Liquid stools may create some problems, solid stools may also create some problems. So now I'll show you with the help of some videos how I actually do it. So this is the first part. There is no audio. I am explaining to the patient. No audio.
वो आपको सामने वो टीवी के अंदर दिखेगा, ठीक है? मैं जैसा बोलता जाऊंगा आप करते जाना है, ठीक है? ठीक है, हिलना नहीं.
Explain the procedure to the patient. Then the second part comes, wherein we are going to do the digital rectal examination. So this is the inspection part, okay? And see, the patient is seeing in the screen, in the small screen, you can see that the patient is actually seeing what is happening to the rectum. And these are the images. You can see this. This is fungal infection. This is the external, this is the abscess, external opening, and this is the fissure in ano, sir just said. So these are the external images that are obtained from video proctoscopy that are going to put in the report. This is the third part of how I do it. So you are actively encouraging the patient, okay, so that he doesn't get the discomfort. So this is DRE that is done, digital rectal examination, and then comes the part of doing the actual video proctoscopy. So wherein this is the transparent anoscope that we are putting inside proctoscope. Transparent because I need to see, otherwise the light will get reflected in a stainless steel proctoscope. So I use a transparent proctoscope. This is the endoscope camera that I hold with the gauge piece. It need not come in contact with the mucosa, rectal mucosa of the patient. Now see, whatever I am seeing, I am showing you here. Okay, and the patient is also seeing what I am doing. Audio.
Centralize. So
I'm constantly telling my assistant who is holding the endoscope to centralize so that this image is a proper image. This is the second screen that I have in my OT.
Centralize. Okay. Photo.
So you can appreciate, right, what the patient is appreciating. You can appreciate very well. See, that is what the patient is seeing. Now for the video, I have switched on the lights. Otherwise, it is a darker room. So you can see the piles, right? You can see the piles in the scope. And this is what is happening. And it is all done. And this is the report that we often give to our patients. Now you imagine if such a report turns up to you, you will be able to, talk to the patient more confidently. The patient will be able to understand more clearly and properly what is happening to him. And even if the patient is referred somewhere else, the consulting physician will know what is happening. So documentation, patient participation. Can I have 2 minutes? visual understanding on symptom correlation, counseling of the patient, and compliance with the treatment becomes better. Real time for assistants and trainees, it is very easy to understand. We can record images, videos. Patient confidence increases via visual understanding. It facilitates follow-up comparisons. Okay, you see what was here and now what is there. It is an office procedure like proctoscopy. No bowel preparation is required. It is readily available, and the problem and the advantage of this is it is self-cleaning. Once there is smudge on the endoscope, all you can do is irrigate. Press the irrigation channel from the endoscope, and the scope will get cleaned. You don't need to constantly take it in and out. So this is a video showing a fissure in ano. Video proctoscopy. You can see the skin tag. And once you have spread, you can see this fissure very well, right? This is the fissure in ano. Now imagine if you are told that what is a fissure is in your residency, there will be no doubt. This is case number 2. This is an acute fissure that bleeds in front of the patient. So the patient understands, okay, this is why I am bleeding. Okay. And this is a video showing grade 2 piles. So this is the video proctoscopy being done. This is the actual patient finding, right? And you can see these piles. They are coming into picture now as you are withdrawing the scope gently, keeping the scope centralized. This is grade 2 piles. Okay, this is grade 2 piles. This is hypertrophic canal papilla that is coming into picture now. And then this is the anorectum, and the proctoscopy is finished. This is the report. Now I'll just skip this video because now this is interno-external piles. So, patient is complaining that something is protruding from my anus. And this is what you can show the patient later on as well in the report that, okay, you have external piles also. This is lax rectal mucosa, mucosa which is just dropping into the proctoscope once you do a proctoscopy. This is another hypertrophic papilla. And then these are the piles that are coming into view, right? You can very well appreciate these grade 3 piles. So grade 3 piles with external component, that becomes our diagnosis. Then this was a patient who came to us with the bleeding PR. Now bleeding PR can be anything. So once you do, this is fungal infection, the infestation the patient has on the gluteal area. So you can record this as well and show to the patient or the dermatologist. Then once you do a proctoscopy, this is the image that you are seeing. Now you can do biopsies also. You have a biopsy channel from the endoscope wherein you can take the biopsy during the same procedure. And you can see this liquid stool and mucus, purulent coming into the proctoscope. You can just take artery, put it inside and mop it, and then continue your procedure. This is a case of fistula in ano. The patient says that something, bursts and keeps on bursting again and again. The patient is seeing this. Okay, this is the purulent discharge, 1, 2 and 3. So complex fistula in ano with multiple external openings. Now some limitations are that standardization is needed in the technique. It is a technology dependent technique. It is also a team dependent technique. And once you give the report to a patient, it becomes an irretractable document. Okay, so you need to give your report very carefully. Video proctoscopy is the way forward. Education, counseling, documentation and follow-ups are the fields that are actually it is meant for. Make use of available equipments. It is not necessarily that you require an endoscope. Whatever you have in your operation theatres, you should tend to utilize it to your benefit. And this armor is an added USP to your proctology practice. I do video proctoscopy in my town. So I become, video proctoscopy karana hai, to aap udhar chale jaiye. So coming back to the more, jungle mein more nacha, kisne dega? Sometimes the surgeons see through video proctoscopy. Thank you.
Thank you, Doctor. Sir.
So I invite you all to WorldCon that is happening in Indore, and we all will definitely meet you there. Make your stay and arrangement more fruitful. Thank you.
All speakers are requested kindly adhere to the allotted time, please. So,
sir, one comment, sir, regarding one thing is here we need a colonoscopy or sigmoidoscopy.
yes.
I have everything, including a colonoscopy, sigmoidoscopy, and that system what you showed.
So you can start from tomorrow
I have-
onwards.
I have that, even a small this kind of camp with
Yes, sir.
but we have this. I can say we don't have in mass patients, like in general hospital, madam is there. They're seeing 100 patients. We don't have any time. The specialty clinic, okay. Corporate hospital, different. Like that, it varies. But anyway.
So imagine the educational.
We adapted furthermore, I can say.
Okay, sir.
Our first year PG's responsibility to take a snap or video and immediately they show it to the patient as well as attendant. We'll show. So that we'll be convinced. Thank you, sir.
Thank you, sir.
No, that is very true. What he has said is true. But one thing, when we were graduating, we were not having perfect